Thank you very much for having me today. What I'd like to talk to you about is clinical trials in children with cancer. The first thing we'll talk about is indeed what even is a clinical trial. At its essence, a clinical trial is a study that tests a new treatment in children or in patients, and we answer three basic questions. Is the treatment safe? Does it work? And is it better than the treatments we already have? This is the gold standard for how we produce improvements in all kinds of therapies in modern medicine, and we will talk specifically today about how we do this in children with cancer. There are three main types of trials in children with cancer. The first is a phase 1 study, which is where we do our early learning about what dose of a drug we should be using, what the toxicities or side effects are of the drug, and what are the pharmacokinetics of the drug. And we'll be talking about pharmacokinetics later, but that is the study of the way that a child's body handles the drug, how much of the drug is in the blood, for example, and how does the body get rid of the drug. Then in phase 2 studies, we talk about what is the activity of the drug, or what kind of tumors does the drug work against. And finally, in phase 3 studies, we try to establish the role of the drug in treatment and answer the question, does this add something better to the best treatment we already have for a particular type of cancer? A really important basic question is, why do we do clinical trials in children? For example, why can we not just take the data and information that we already know from adults with cancer and extrapolate that to children? And that's what I'll spend most of my time today talking about. So the first reason is that children are really not just small adults. Their organs are still developing, their body composition, the amount of water, muscle, and so forth in their body is changing. And those two things have a major effect on the pharmacokinetics of the drug, or how the body handles a drug. In addition to pharmacokinetics, the responses, both good and bad, of a child's body to a drug can be different from how an adult's body responds, even with the exact same dose and the exact same amount of drug in the blood. And we call that kind of response pharmacodynamics. And finally, completely aside from how the bodies of children and adults are different, there's also a difference in the kinds of tumors that children and adult gets. And we'll talk about each of these points. So first of all, body composition, which affects pharmacokinetics. So when a child is born, the child is very much full of water compared with what an adult body is. And in fact, at birth, about 75% of a child's weight is made of water. By the time you're an adult, only about 55% of your total weight is made of water. In addition, in a newborn, about 45% of that water is what we call extracellular water, meaning it's the water that is in your bloodstream and in the tissues and outside of the cells in your body, whereas by the time you're an adult, only about 20% of your body water is extracellular. These differences have a big impact on how drugs get distributed through the body, and you can imagine if you take a drug and you dissolve it in some amount of water, if you have more water, the drug will dissolve differently than if you have less water. And so body composition is an important aspect of drug distribution. In addition to the changes in body composition from the newborn period to adult composition, we also see changes in renal or kidney function. So the kidneys are our filters, which help clear toxins and drugs like chemotherapy from the blood, and the flow of blood to the kidney is decreased at birth. In addition, something that we call the glomerular filtration rate, which is how fast the kidney is able to filter things from the blood that's presented to it, is also decreased at birth. So in the newborn, that rate is about 25 milliliters per minute per 1.73 meters squared, and that 1.73 meters squared is a unit of body size or body surface area that we use so that we can compare small people and big people and normalize all to the same standard. So that rate is quite low. It doubles in about the first week of life, and by the time a child is about 1 year of age, the GFR has reached its adult rate of about 100 milliliters per minute per 1.73 meters squared. kidneys also have a function called renal tubular function. And this is related to the way that the kidney actually secretes substances into the urine so that it can be cleared. And renal tubular secretion is quite low at birth. Like the glomerular filtration rate, it matures as a child gets older, but it takes longer to mature. So even within the kidney, there are differences in the maturity of function between younger children and older children, and between different aspects of renal function. Liver function is also different at birth than it is in older children and adults. So what we call the phase 1 enzymes, which help to break down chemotherapy and other drugs, are decreased at birth, and there are different types of these enzymes which all mature at variable rates. Some of them mature quite rapidly in the first week or few weeks of life, and others take several years to reach the mature adult level. There are also enzymes which we call the phase 2 enzymes, and these enzymes take the broken down metabolites and attach other molecules to them that help your body get rid of them more easily. Some of these enzymes, like the enzymes in a pathway called glucuronidation, are decreased at birth but increased very rapidly, whereas some of the enzymes are actually functioning at a higher level at birth than they eventually will be in the more mature adult body. And so when you put these variables together, you can see how liver function in a child, along with renal function, will be quite different from in the older child and adult. And this means that how a child's body handles the drug will be much different in the youngest children compared with older children and adults. So we can't just make assumptions about how adult bodies handle drugs when we're trying to learn how a child's body, and especially a very young child's body, will handle the same drug. In addition to the differences in the way that the body and the organs handle drugs, there's also can be a difference in the sensitivity of different organs to drugs. And we call this difference in sensitivity a pharmacodynamic effect. So here is an example from a drug that we studied a number of years ago in children called 9-cis-retinoic acid. And the major toxicity of this drug in both adults and children is toxicity and increase in pressure in the brain, leading to symptoms like headaches that limit how much of the drug that you can use. What you see here in the bullet points is that in children under the age of about 12 years, the largest amount of drug we could give was about 33 milligrams per meter squared per day. Meter squared is a measure of body surface area, which is basically a function of the size of your body. That amount was about half the dose that we could use in children who were older than 12 years old, and the amount that we could use in those children was still only about half of the amount that adults could tolerate without having these neurologic symptoms. Yet the pharmacokinetics were not different. So the amount of drug that you measured in the blood at any given time, for example, was very similar in young children, older children, and adults. And yet the ability of the younger bodies to tolerate the effects of the drug was less. And we call that a pharmacodynamic difference. And that is not something that you would be able to predict or guess from the adults to the children. That drug was based on body surface area, which is a way of thinking about what size your body is. And that is something that we do with most drugs in pediatric cancer clinical trials. So the picture that you see here shows the percent of adult size, adult body size on the y-axis, and the age of a person on the x-axis. And the line by body surface area is the line that shows how your body grows. And everybody knows that children start out small, so in that sense they are small adults. And when you're born, you're something like a 10 or 20% of the size that you'll eventually be when you're a grown adult. And through childhood and puberty, until you hit the end of puberty, 18, 20 years of age, there's a relatively steady and gradual increase in body size. But importantly, children's central nervous system, so their brain and their spinal cord and the spinal fluid, which is the fluid surrounding and bathing the brain and spinal cord, are bigger in young children compared with adults. And that's the top line you see in the picture, where first of all, if you've ever looked at a baby, you actually recognize that the child starts out with a big head proportional to their body size, about 40% of their grown adult head size. And that matures very rapidly because the brain of a child grows rapidly. And by the time children are 4 or 5 years old, they've almost attained their adult brain volume. And the reason that this is important in pediatric cancer therapy is because cancer cells, especially the cells that cause diseases like acute lymphoblastic leukemia, one of the most common childhood cancers, those cells can hide in the central nervous system. And to treat those cells, we put chemotherapy directly into that spinal fluid by doing what's called a lumbar puncture or a spinal tap. In the early days of chemotherapy, the 60s, 70s, and into the early 80s, we would give a child's intrathecal therapy based on their overall body size. But it turned out that that was actually underdosing the smallest children because their CSF volume was actually big relative to their body size. And what you see here in the top part of this picture is that green and yellow bar shows that about 25% of children who had leukemia would have a relapse or a recurrence of their leukemia in the spinal fluid. And that invariably led to a bone marrow relapse and then usually to the child not surviving their leukemia. But in the mid-80s, when we recognized this phenomenon related to the growth of brain and spinal fluid volume, we started giving children a bigger dose based on their brain size and CSF volume, not based on their body size. And what you see in the lower half of the panel is that that CNS relapse rate decreased to about 10%. And so this had a very important impact on our ability to cure children with leukemia. And in fact, now, in a chart that would be familiar to any pediatric oncologists in any audience, you see that we give children the doses of their therapy in this central nervous system or in the CSF based on their age, nothing to do with their weight or body size. And by about the age of 3, children get the same doses of intrathecal chemotherapy as we give to adults. In addition to all of these differences between children's bodies and adult bodies, there are also very important differences in the kinds of cancer that children get compared with adults. And so adults, as you all know, most commonly get cancers like lung cancer, breast, prostate, colorectal, and bladder cancer. And leukemias are only about 9th in the list of tumors in adults. Whereas in children under the age of 15, leukemia is the most common diagnosis, followed by brain tumors, neuroblastoma, Wilms tumor, and non-Hodgkin's lymphoma. So there's not much overlap in these two lists. So if we only did studies in adults, we would be missing treatment for all of the common causes of childhood cancer. And even within tumors that seem to be the same, there are often important differences. So children, for example, get a type of tumor called GIST, and adults get the same type of tumor, and they look exactly the same under the microscope. But in the adults, more than 80% of patients have certain kinds of genetic mutations within the tumor that drive the growth of the tumor, whereas children don't have those mutations almost ever. And similarly, in a kind of brain tumor called glioblastoma, if you just looked in the microscope, you would think that the tumors in children would be exactly the same as the tumors in adults. Yet, the adult tumors have different genetic changes compared with the pediatric tumors. This kind of thing is especially important now in the age of targeted therapy, because if we assumed that drugs worked in adults and would also work in children, based on what we saw under the microscope, we would be wrong because children have a different set of genetic mutations or may not have any of the same genetic mutations. So again, we need to look separately at pediatric and adult versions, even of tumors that we call the same thing. Now, when we do these clinical trials in children, there's actually quite a challenge in terms of having enough children to enroll in the clinical trials. In some ways, this is a good problem. So adults, in a recent year, there were about 1.7 million new cases of cancer in adults, and about 600,000 adults died of cancer. Whereas the same year, children, meaning in this case under the age of 19, there were about 16,000 new cases and about 1,800 deaths due to cancer. So we're glad that we only have about 1% of the cases and 1% of the deaths in children as in adults, but it makes it even more compelling to do very careful clinical studies to improve the treatment for childhood cancer. And almost all of our studies now are done in what we call a cooperative group setting. So this is where many of the leading children's hospitals in the country and indeed in the world will work together to answer very important questions about the treatment of pediatric cancer. And just as an example of why we have to work together, the most recent Children's Oncology Group, one of these very large cooperative groups, the most recent study of a common form of childhood leukemia required over 9,000 children to answer the questions about which treatments would turn out to be better. And it took almost 8 years to get all of those children enrolled into clinical trials. So it's very important that we do these clinical trials very carefully in very large groups. Even though the numbers are small and we encourage everyone who's interested to enter a clinical trial if it's available, it's really important to understand that only people who want to be in clinical trials enter them. So if a family thinks that a clinical trial is not the right thing for them, that's completely fine. Patients have to volunteer and they have to give their consent freely to enter a clinical trial. And for children who are too young to actually legally sign and give their own informed consent, the parents have to give permission for the children to enter the trial. The trial has to be reasonable, and what we call the risk to benefit ratio has to be reasonable. And this means that whatever bad things we can anticipate in terms of drug side effects or other problems might happen from the clinical trial, there has to be a good reason to think that there might be benefits either to the individual child or to society as a whole to offset those risks. And there also has to be equipoise. Equipoise is a term in ethics that means we truly don't know the answer to the question. So we are not sure if the new treatment will be better than the previous treatment. And if we knew the answer to that question, we would not need to do the clinical trial. There's a very large amount of safety and oversight that helps us make sure that clinical trials are as safe as possible. So the Food and Drug Administration, or FDA, oversees the study of all drugs and devices in both children and adults. A group called the IRB, or Institutional Review Board, reviews every clinical trial to make sure that the design is ethical and to make sure that the process for telling people what will happen to them in the study or telling parents what will happen to their children in this study is very accurate and a good informed consent process. For children in clinical trials, there are additional protections. So compared with adults, there are more rules and limitations around the risks that children can take. And we seek the assent of children. So even though I mentioned that they're too young to formally give their consent, children, usually over the age of 7 or in some cases over the age of 14, have to agree at a level that's appropriate to their own current developmental understanding to participate in the trial. And then once a trial gets started, there's a group called a Data Safety Monitoring Committee that regularly looks at all of the adverse events as well as all the good things that have happened on a trial to make sure that it continues to be safe to enroll more patients in the studies. How do we know this is a good idea? This is a picture of the changes in survival from the most common cause of childhood cancer, acute leukemia, from the 1960s until now. And every line represents a different 5 years. So what you see on the y-axis is the survival rate, and on the x-axis is the years from diagnosis. And so on the very bottom curve in the late 1960s, At about 5 years and certainly 10 years after a diagnosis of childhood leukemia, only about 10% of children were still alive. But you can see that this improved gradually through the early 70s, later 70s, until now in the mid-2000s, what you see is that at 5 years after a diagnosis of leukemia, more than 90% of children are still alive after their diagnosis. These improvements, and you can see them for many, many tumors in children, these improvements are entirely due to clinical trials that tested new treatments, showed which treatments were better, showed us how to treat childhood cancer more safely and more effectively. So in conclusion, I hope I persuaded you that children really aren't just little adults. Careful clinical trials are the key to improving the outcome for childhood cancer, and all of us need to work together to ensure that trials are done properly so that we can answer these important questions and continue to improve the outcomes for children with cancer. Thank you.